Good afternoon, everyone. I welcome all of you to this webinar on multidisciplinary management of gallbladder carcinoma with Dr. Shraddha Patkar, Dr. Rakesh Kapoor, and Dr. Prabhat Bhargava. I thank all the panel members for sparing their valuable time and giving us an opportunity to learn from them. So I welcome all of you for this webinar. Dr. Shraddha Patkar is Professor of Surgical Oncology, GI and HPB Services, TMH Mumbai. Welcome to the webinar, ma'am. Dr. Rakesh Kapoor is Professor and Head Radiation Oncology, Tertiary Cancer Care Center, PGI, Chandigarh. Welcome, sir. And Dr. Prabhat Bhargava is the Associate Professor of Medical Oncology, TMH Mumbai. And I welcome Dr. Prabhat Bhargava also. I welcome, sir. So Navya is a cancer informatics and patient services center, services company. It leverages technology to provide personalized evidence-based cancer treatment plans with the help of experts like we have in the panel today. And we also work with the state government hospitals and cancer care centers to work towards standardization of cancer care through adoption of national cancer grid guidelines for effective treatment of cancer for their patients. So with this short introduction, I will move on to introducing the panel of experts. Dr. Shraddha Patkar, I welcome you, ma'am. She has 15 plus years of experience in surgical oncology. Her special area of interest are gallbladder cancer and retroperitoneal tumor surgeries. She established a retroperitoneal tumor clinic at TMH to help standardized treatment guidelines. She is a member of research review committee. She has authored 130 plus publications in various peer-reviewed journals, and she has contributed actively to numerous book chapters. So she has a very good academic background and research background, and is a very good clinician. So I welcome you, ma'am, and it is our honor to have you on this panel today.
Thank you.
Dr. Rakesh Kapoor has 20 plus years of experience in the field of radiation oncology. His special interest is in brachytherapy of various organs, including bile duct. He is on advisory panel of various national and international agencies working on healthcare standardization. He has published 200 plus research articles and delivered 170 plus talks at national and international platforms. He has pioneered the technique of in vivo dosimetry in brachytherapy of CA anal canal, which has been presented at ESMO. And it's our honor to have you on this panel today, sir. Your support to us has been excellent, and your experience has been very much helpful to many of the patients and to our webinars as well. I welcome you, sir. Dr. Prabhat Bhargava, he is Associate Professor of Medical Oncology. He has 10 years of experience in medical oncology. He has received ESMO Merit Travel Grant multiple times for his research work. And he has received Terry Fox Research Institute grant for his research on metastatic biliary tract cancer. He is a principal investigator for several oncology clinical trials, and is a member of several national and international medical oncology associations. He has published 50 plus research articles in various peer-reviewed national and international journals. And he has helped us a lot in many of the scenarios. Many patient testimonials have been indicating that. Thank you, sir. Thank you for being on this panel today and helping us out with the webinar. I welcome you for this webinar today. Okay, sir. So with this short introduction, we would proceed with the case presentation. I welcome Ms. Bhavna.
So I'll be presenting our first case today. So it's a 58-year-old female who presented with a 58-year-old female with a family history of cancer. Mother had throat cancer. Also, patient is a known case of asthma, type 2 diabetes. Am I audible now? Yes. Yeah. Sorry. So patient is a known case of type 2 diabetes on metformin, known case of hypertension on telmisartan, known case of hypothyroidism on thyroxine, also a coronary artery disease patient. She's on aspirin, clopidogrel, and bisoprolol fumarate. She presented with complaint of upper abdominal pain, constipation, nausea, vomiting, cough on September 2022. Her CT abdomen pelvis showed partial gallbladder distension with 0.78 centimeter of gallbladder body and fundic wall thickening, mild stomach, cardia, and pyloric region thickening, September 13th, 2022. Her CEA 19.9 was 9.3, September 21st, and CEA was 2.67, September 21st, 2022. Her CT triphasic abdomen pelvis showed 0.4 centimeter gallbladder circumferential wall thickening, gallbladder distension, and multiple gallbladder mucosal surface polypoidal lesions, largest 0.3 to 1.4 centimeter, luminal projections, and few periportal lymph nodes, largest measuring 0.8 centimeter, September 29th, 2022. Her radiology note was suggestive of gallbladder polyps with periportal lymphadenopathy and multiple large polyps of mitotic etiology. Her FTG PET-CT of October 2022 showed multiple gallbladder polypoidal lesions with SUV7, extension to lumen, partial gallbladder distension, subcentimetric bilateral level 2 cervical lymph nodes with a low FTG avidity. She underwent curative definitive upfront diagnostic laparoscopy, adenolysis, radical cholecystectomy, bile duct excision, hepatojejenostomy, and jejunojejenostomy on October 26, 2022. Operative note, multiple large periportal, perihepatic, and periceliac lymph nodes, adenomatous gallbladder thickening. Pathological tumor size was 2 into 1.8 centimeter. 8 regional lymph nodes were dissected, of which none of them were positive for tumor deposits. Malignant disease adenocarcinoma. Pathology note suggestive of invasive adenocarcinoma of biliary type. Liver shows periportal inflammation and fibrosis. Cystic duct shows focal ulceration, chronic inflammation and congestion. Pyloric dysplasia. Cancer grade 3, perimuscular connective tissue invasion was positive, lymphovascular invasion was positive, perineural invasion negative, IHC positive for slide block review, CK7, CK19, CK7, IHC negative for CD56, CGA synaptophysin, Ki67, 70 to 75%, pathological TNM stage 2 TB N0M0. FDG PET-CT of November 24, 2022 showed perihepatic and gallbladder fossa loculated collections, SUV 5.5, peripheral thickening, subcentimetric level 2 cervical lymph nodes, low FDG avidity, no evidence of malignancy elsewhere. Radiology note, in comparison to previous PET-CT dated October 14, 2022, the gallbladder lesions are no longer seen. Complete blood count of November 8, 2022, low hemoglobin with 9.1, platelets elevated to 840,000, RBC came down to 3.2, WBCs elevated to 16,300, creatinine was within normal limits, LFT total bilirubin a little high, 1.3, alkaline phosphatase 382, again elevated, cardiac function test was not available. Functional ECOG score of this patient was 1. General condition, was able to do all the daily living activities without any assistance. Symptoms include abdominal pain, cough, weight loss. Patient has resource constraint, however, desires to know all the options. Navya questions were: consider adjuvant chemotherapy with capecitabine versus role of concurrent chemoradiation therapy with 5-fluorouracil with recommended RT doses versus alternate, and role of additional diagnostic tests.
Dr. Rakesh Kapoor, can you please comment?
So, first of all, thank you, Bhavna. I think you have elaborated in detail. I'll touch 3 points which are important. One is, in this patient, the preoperative CT shows there is a periportal lymphadenopathy. And in the postoperative, hello?
Yes, sir, please continue.
You cannot hear me?
We are able to hear you, sir. Please continue, sir.
In the preoperative CT, there are periportal nodes, but after the surgery, it is a N0 disease. So there are either I don't know what is there because surgery has been completely done. So there are no nodes visible in the histopathology comment is N0. That is one thing which I'll keep as a point indicator that she has lymphadenopathy. Now it has not been proven in the post-operative setting. But CT showed lymph node, PET did not comment it on that. The second, in the histopathology, you have the lymphovascular invasion is there. So that is a pointer which showing that this is a high risk disease. Otherwise, patient has a disease which is T2 and it is a limited disease to the muscularis only. It has not gone beyond that, neither towards the abdominal peritoneal side nor towards the liver side. So it is T2 as far as N0 as mentioned by the histopathology, but a possible lymphadenopathy shown in the preoperative. Yeah. Am I right? Just see the CT finding. CT. So in the CT, few periportal lymph node, largest 0.8 centimeter. No, this is September 22. Radiology note, periportal lymphadenopathy is mentioned.
Yes.
Okay. Now she is ECOG 1, and we know that in gallbladder malignancy, if the lymphovascular invasion is there, and there is a doubtful periportal lymphadenopathy also mentioned, from my personal point of view, will be we should give both chemotherapy as well as radiotherapy. Now the choice whether it is to be concurrent or if as the ECOG is 1, so I think she can very well tolerate the concurrent chemoradiation. My suggestion will be to go with concurrent chemoradiation. Further to strengthen that, we have already seen, now there are no head-to-head comparative studies, but if you look at some of the studies which are published in the journal, the retrospective reviews by Halim et al. And also the European Journal of Surgical Oncology, patients where the post-operative radiotherapy was given in such high-risk features like lymph node positive, lymphovascular invasion, the local controls have definitely improved and those patients have done better as compared to only chemotherapy. So that will be my stake of starting it. Even there was a study done from the Tata only by Reena on the POL CGP study where they tried to do it on the potentially resectable or unresectable patients where they gave neoadjuvant chemoradiation versus the chemotherapy only, and they found that neoadjuvant chemoradiation helped in downstaging also, and the role of radiation was better. So this is my take on this.
Thank you, sir. Now I request Dr. Prabhat Bhargava to add his points.
Yeah, considering it is a T2N0 disease at present with query inadequate nodal dissection, because of the query inadequate nodal dissection, I would like to give adjuvant chemotherapy to this patient.
Prabhat, I don't think the nodal dissection is inadequate. The patient has undergone a bile duct excision that can as good as it gets. They might have not harvested, and anyway, according to AJCC, 6 nodes are sufficient. So 8 is adequate.
No, with the peri, initially it was seen on CT scan.
Peri may not always correspond to past nodes. No, they might be enlarged for whatever reason. They have harvested adequate, and they have done a bile duct excision. So they would have removed everything which is there. I don't think no.
Okay. Okay.
But you can give whatever. You can err on the side of caution and give because it is T2. You don't know the.
It is T2N0. Yeah. Very good prognosis otherwise also. But if we want to err on the side, we can give 8 cycles of capecitabine. But patient per se has good prognosis because of T2N0 nodal disease. May not, obviously prospective studies are not there in this category of T2N0. Otherwise, adjuvant chemotherapy is warranted. So I will err for this early stage patient also to give 8 cycles of chemotherapy with capecitabine. Hello?
Hello, yes, sir. Sir, Dr. Rakesh Kapoor, can you add any, the dosage or any recommendation on the radiation? Hello, I request the participants to keep themselves on mute. We are getting a lot of disturbance in between. Please, please continue, sir.
agree with Dr. Patkar, and I also agree with Dr. Prabhat also. The patient definitely has undergone an excellent surgery. There is no doubt about it. Sometimes the lymph nodes are not harvested also. That is one possibility. But there is another factor which is very important. That is lymphovascular invasion, and it is positive. So this is a very high indicator for a local recurrence in patients of gallbladder carcinoma, as we have seen it in clinical practice. So from my point of view, what we follow in PGI is if there is any high risk factor associated even with T1 patient or a T2 patient, we don't leave the patient, we give adjuvant treatment, whether chemotherapy alone or chemoradiation, that depends on two situations. One is we look it into that where is the primary disease which has up to what location it has gone, and number two, what is the ECOG scoring of the patient. So if the patient has low ECOG, then we start with one treatment, either mostly a adjuvant chemotherapy only. But in such patients where the ECOG is 1, younger patients are there, we usually add radiotherapy also along with chemotherapy.
Right, sir. Any questions from the participants? I think we can move on to the second case.
I can't see anything in the chat box also.
Yeah, nothing is there, sir, so far.
So, Sharda agrees to what I say, or he says still adjuvant is required both from my side, Sharda.
Yes, sir.
As far as lymph nodes they have been detected, I understand it is adequate. But many a time because LVI is positive, so we don't leave such patients.
Yeah, I agree.
Shall we, okay, adjuvant. So can we move, shall we move on to the next case then?
Yes, yes, please.
So moving on to the next case. The next case is 46-year-old female with no history of family cancer, past medical history, nothing significant, presented with complaint of right abdominal pain on January 2024. She was on a self-medication for abdominal pain, but as it became unbearable, went to hospital. CT abdomen pelvis showed 3.4 into 2.3 centimeter gallbladder, superior lateral wall thickening, appendix inflamed, small loculated collection adjacent to the base of appendix, suggestive of acute appendicitis, no evidence of malignancy elsewhere. February 1st, 2024. So she underwent a diagnostic laparoscopic appendectomy and cholecystectomy on February 2nd, 2024. Her operative notes were not available. Pathological tumor site gallbladder. Her pathological tumor size was 4 into 4 centimeter with final surgical margins negative. Regional lymph node resected was 1. Malignant disease invasive adenocarcinoma. Pathology note showed with intracholecystic papillary neoplasm, mixed type with high grade of dysplasia. Cystic duct margins is free of invasive carcinoma but reveals low grade dysplasia. Cancer grade 1, muscularis propria invasion was noted. Note, the appendix showed acute diffuse spurative appendicitis with periappendicitis. Pathological TNM stage was stage 1, T1B, N0M0. FDG PET-CT post-surgery showed post-cholecystectomy, mild hepatomegaly, no evidence of malignancy elsewhere on February 26, 2024. Radiology note showed no focal abnormalities, FDG avid lesion at operative bed, no focal abnormal FDG avid lesion in the rest of the body. Her CA 19.9 was 13.6 and CEA 1.5 on February 18, 2024. Her CBC showed low hemoglobin, 9.6 on February 2nd, 2024. RFT was within normal limits. LFT alkaline phosphatase was elevated on February 1st, 2024. Cardiac function was not available. Her functional status was ECOG 0 to 1. General condition, able to do activities of daily living without assistance. No significant disease-related symptoms. Patient has no resource constraint. Patient preference note, she's working in Dubai. The surgery happened in Dubai, and post-surgery, she is currently in India with a 15-day emergency visa. She visited an Indian hospital in which PET-CT was done, and the oncologist recommended immediate resurgery with completion surgery and chemotherapy. She's very anxious as the oncologist in Dubai explained to her that surgery was complete and she does not need any further treatment. But currently, the oncologist in India is recommending immediate surgery. She's in India till March 15, 2024. So she wants to know if surgery is recommended, and if recommended, could it be postponed to the start of April 2024, as she will be back to India with visa for a month. Also worried about the need for chemotherapy. Her current treating oncologist recommended immediate surgery after seeing the PET-CT. Navya questions, given surgical histopathology is suggestive of excision with negative margins and recent PET-CT is suggestive of no evidence of malignancy, role or need for completion surgery now versus other surgical interventions, role or need for chemotherapy with capecitabine or Capox or single agent 5-FU or gemcitabine versus fluoropyrimidine-based chemoradiation versus observation versus clinical trial versus alternate, are any additional diagnostic tests recommended?
Dr. Patkar, I think you can start with the surgical inputs.
Yeah, so the crux of the matter here is what is the T stage of the disease. So if we are able to conclusively say that it is T1B, then we need to explain to the patients that although it is still stage 1, the chances of lymph node metastasis are still there, although they are less as compared to if a disease was in T2 or T3. But it is still a significant risk. It's around 10 to 15% reported in literature. Our own DMH data says it is 21%. That is 1 in every 5 patients of T1B is going to harbor a node positive disease, which automatically will upstage. So unless you do a revision surgery and clear all the lymph nodes in the hepatoduodenal ligament, you will never be able to stage the patient properly despite your best imaging, even if your PET is negative. So ideally, if the patient is concerned, this is what we would explain. And then again, because she is early, it is more prudent to be more aggressive in these patients. So leaving her alone will put her at a risk of understaging. And if in the final histopath it is still node negative, then I would probably not add chemotherapy. But that is, we would leave Prabhat to decide. But that's my take on this.
Ma'am, there are some more questions like can we wait for 1 more month and all that, like for a completion surgery, like whether it is advisable to wait or is it
so
okay to
timing
wait?
of revision surgery is debatable. There are various things reported in literature to wait for 4 weeks for the inflammation to subside. Some studies have reported that 4 to 8 weeks is the ideal time to intervene. When we looked at our own data, we found that patients operated within 10 to 14 weeks fared the best. But having said that, the most important thing is to undergo the revision surgery. There is no lower limit or upper limit to when it can be done. As long as the patient is non-metastatic on whatever imaging is available, should go ahead and do the revision. Because that ultimately is going to stage the patient properly and help us decide whether any adjuvant is required or not. And so 1 month is not going to change anything.
Is there any guideline on deciding on the completion surgery, ma'am? Like any specific like finding
So
is
as
there?
a rule of thumb, and anybody who has a T1B disease and who has any imaging which shows nodes or any residual disease in the gallbladder fossa will need a revision surgery. Because the reason is that with your best of imaging modalities, you can never be sure that the nodes in the PET scan are negative unless you actually remove and send them for histopathology.
Thank you, ma'am. Dr. Prabhat Bhargava, can you please add your points?
Considering that repeat surgery has been done and no further nodes were positive, I would like to observe this patient.
Okay, no role for chemotherapy.
No adjuvant chemotherapy in T1B disease.
Okay, sir. Okay. Sir, anything from the radiation oncology? Any role here?
Thank you, Prabhat. I think Dr. Patkar has made our point. From radiation point of view, there is no role of radiation. But just as on other side, just to add to decrease the worries of the patient if she has to be on, say, close follow-up, keeping in view her other the parameters, logistics which she has mentioned on the Navya portal. Partner, one thing which I like to highlight from here is, please go to the pathology notes once again, the detailed pathology. Yeah, just keep it. So, two things are there which are important, just to reassure her if she doesn't want. I fully agree. Anything beyond one, a simple cholecystectomy may not be adequate because it is 1B, so you need a complete surgery. That is clear. Many surgical series have shown that after 3 years, if only you do a simple cholecystectomy in those patients, then chances of lymph node metastasis are more, which you have already spoken. The only thing I like to highlight here is how it is 1B, but it is having the 60 chunk margin is 3. It is E1B. There is low grade dysplasia on that side, and it is a papillary neoplasm, so which is a favorable neoplasm. And secondly, in these circumstances, if we look at the overall, the pattern and other things, if she wants to gain some time, now there is no period mentioned as she has said, but these can be reassuring things to her from Navya side that you can gain time and then go ahead with the resurgery after that is done. So that is my advice to reassure the patient also that if she is waiting, what would be the possible reasons for her re-waiting.
True. Agree.
Sir, sir, there is one question, whether combined chemoradiotherapy is preferred in resection margin positive, or I should say, like, if resection margin is positive, what are the approaches that we have to adopt?
Previous one you are talking.
Yeah, okay, yeah.
The previous case or this case?
Previous case, I think, yeah.
I think if they meant in general, the question was
In
that
meant in general, it is not specific to the case.
I said in general, there is no head-to-head comparison of that group of patients. But
Okay, sir.
no, we have to go back to the history of the carcinoma gallbladder. If you look at the incidental cholecystectomies which are done in patients of gallstones, where incidental CAGB has been found, where inadequate surgeries were done later on retrospectively, once they saw that the patients who had margin positive or who had lymphovastatic invasion or who had node positive disease, they all recurred. And they had not only local metastasis, but chances of distant metastasis are as high as 40 to 50%. So at that time, you can't offer anything in the curative setting. So it is better to treat now and give adjuvant radiation in this group of patients. So from my clinical sense, I'll say that now the head-to-head comparisons are not there, but still there should be addition of radiation. Chemotherapy has to be given, there is no doubt about it, but you should add local radiation in such group of patients where there is localized disease completely rejected with high risk margin like LVI positive, lymph node positive, or if the disease is T3A or B both. This is again a locally advanced malignancy. There also adjuvant radiation should be.
Sir, I think there is one more question. Detecting gallbladder cancer in its early stages remains a challenge. Are there any specific biomarkers or imaging techniques that could improve early detection rates? What are the most cost-effective and reliable screening methods for identifying individuals at risk? I think it is basically trying to ask that the gallbladder cancer is presented most of the times in late stages, or it is detected incidentally, but not as a screening detection or anything. So, is there anything that is available in the pattern of like biomarker or imaging technique or something to detect early, and what are the individuals at risk factors?
Naga, the person who has asked this question, two things should be made clear to the person. One is, at present, there are no specific biomarkers or imaging studies which are available. However, there are studies going on at present in patients who have practically those who have gallstones. And in certain forms of gallstones, we have seen that in those patients, there are higher chances of having a carcinoma gallbladder. So those patients, we are taking them, they are at-risk patients. This study is still going on. I cannot disclose
Yes, sir.
everything on the study. I think Tata is also one of the participants in that study. And 2-3 more centers are involved. Guwahati is also involved. So we are taking the nail and hair of the patients of gallbladder, those who had stones, and reanalyzing the stones of those gallbladder patients. And we are trying to analyze what chemical composition of the stones were there. Because we know that the sub-Himalayan belt, the CAGV, there are a lot of cases and incidents is more. So in those patients, we may be in a position to develop some biomarker related to the occurrence of more of gallstone. As such, if you ask me some tumor marker, it is not available. There is no imaging study as a screening tool which can be done for detecting the gallbladder, like for screening the gallbladder. But once there is a polyp or there are soft pointers towards, say, for example, a polyp which is more than 1 to 1.5 centimeters, more than 3 polyps. So these are the indicators which are usually taken, and even if the patient doesn't have malignancy, we send them to the surgeon and they do surgery in those patients who are asymptomatic. But I can't say with authenticity that this is a screening tool used for those patients.
Sir, thank you so much, sir. Any other questions from the participant? I think there is nothing. Can we move on to the next case?
So coming to the third case, it's a 45-year-old female with no family history of cancer. Patient is a known case of hypothyroidism on levothyroxine. Patient presented with complaints of abdominal pain on October 2022. Note, patient had developed similar pain 2 years ago. Then he was fine again in October 2022, started having severe abdominal pain. FDG PET CT of the patient in October showed 7.9 into 2.1 centimeter gallbladder lesion with an SUV of 11.8, multiple liver segment 4A, B, SUV 10.8 lesions, segment 5, SUV 11.5, segment 7, SUV 7.3, segment 8, SUV 4 lesions were noted. No evidence of malignancy elsewhere. Radiology note findings suggestive of intense metabolically active gallbladder malignancy associated with extensive hepatic metastasis to liver. Diagnosis made by core biopsy of the liver showed large cell carcinoma of grade 3. Slide block review of the same showed large cell carcinoma grade 3. Pathology note, high-grade large cell carcinoma with neuroendocrine differentiation. IHC was positive for CEA, chromogranin, cytokeratin 7, cytokeratin 20. IHC was negative for CD34, CD56, CD117, chromogranin, E3, GATA3, HEPAR1, Melan A, P40, PAX8 and TTF1. Ki67 showed 80%. CT abdomen pelvis of October 15 showed moderate gallbladder distension, completely filled with lobulated lesions, adjacent liver segment 4B and 5 invasive lesions, largest 3.8 into 2.9 centimeter, segment 5 anterior inferior lesion 2.9 into 2 centimeter, liver segment 5-8 lesions of lesion, 1.8 into 1.4 centimeter liver dome segment 8 lesion, 0.9 into 0.6 centimeter epiphrenic lymph nodes, no evidence of malignancy elsewhere. Radiology note findings are suggestive of gallbladder neoplasm. Arterially enhancing lesions are demonstrated in adjacent liver in segment 1B, 5, which may reflect local invasion. Further solid right liver lesion suspicious for metastasis. Small anterior epiphrenic nodules are equivocal but could be metastatic. Metastatic epiphrenic lymph nodes, yes on radiology. Diagnosis of slide block review of the liver lesion showed metastatic carcinoma of grade 3. Pathology note, metastatic high-grade undifferentiated carcinoma from a clinically detected gallbladder primary. Clinical TNM stage was stage 4, NET, NEN, M1. Patient was started on first-line palliative chemo and targeted therapy with cisplatin, gemcitabine, and durvalumab from October 24, 2022 till December 2022. Complete administration details not available. CT abdomen pelvis in January showed disease progression. Gallbladder neoplasm stable with 4.8 into 3.6 centimeter right liver lobe segment 5 lesion, 3.6 into 3.1 centimeter right liver lobe segment 5 into 8 lesion, 4.2 into 2.4 centimeter right liver segment 8 lesion, 2.2 into 2.2 into 1.8 centimeter right liver segment 8 subcapsular lesion, 0.7 into 0.3 right pericardial lymph node, and no evidence of malignancy elsewhere. Radiology note, there is progression of disease with progression of liver metastasis. CT abdomen pelvis of January 25th showed 7.5 into 3.1 centimeter gallbladder lesion, 3.5 into 3 centimeter liver segment 4B 5 lesion, 3.1 into 2.9 liver segment 5 lesion, hepatic steatosis, no evidence of malignancy elsewhere. Radiology note, the gallbladder mass appears similar, mild decrease in size of hepatic metastasis, non-measured lesions present, increased, decreased, absent, now normal. Patient underwent second-line palliative immunotherapy with ipilimumab, nivolumab from February 8, 2023 to ongoing at present. Note, complete administration details not available. CT angiography showed multiple right lung pleural base lesions, largest 1.8 centimeter, metastatic, right side pleural effusion was noted, compressive atelectasis, collapsed right mid-lobe, right lower lobe, lung arterial tree subsegmental level opacifications, March 21st, 2023. Radiology note, right-sided malignant pleural effusion with right pleural metastatic disease. CT abdomen pelvis of March 21st, 2023 showed gallbladder lesion, distension, multiple right liver lobe lesions, 50% of the left liver lobe extrinsic compression of portal vein at porta hepatis, non-enlarged portocaval lymph nodes, no evidence of malignancy elsewhere. Radiology note, gallbladder malignancy with widespread hepatic metastatic disease. There was metastasis to lung, yes. CEA 1000 high on March 21st, 2023. CA 19.9 was normal. CBC on March 21st, 2023 showed WBC of 11,000, monocytes of 1.37, hemoglobin of 10.7, low, serum creatinine, RFT serum urea of 1.6, which was low. Serum sodium was 131, low. Serum calcium 2.68, elevated. LFT on March 21st, 2023 showed phosphates low, 0.76. Total bilirubin elevated to 30. AST elevated to 130. GGT elevated to 757. Alkaline phosphatase elevated to 542. Albumin elevated to 33. Globulin elevated to 44. LDH elevated to 481 and TSH of 2.58 within normal limits. Cardiac function not available. Functional status or ECOG score of patient is 1. Patient is able to do daily living activities without any assistance. Symptoms include acute abdominal pain, itching, headaches, insomnia, shortness of breath. Patient has no resource constraint. Currently, patient has completed 2 cycles and her liver enzymes have elevated, to which the treating oncologist said might be due to blockages in the ducts. Consider ongoing immunotherapy with nivolumab plus ipilimumab versus FOLFOX versus single agent nivolumab alternate, role of stenting, role of palliative radiation therapy to lungs, and role of additional diagnostic tests.
Thank you, Bhavna. Now I request Dr. Prabhat Bhargava to comment on the case. Sir, please.
You are giving immunotherapy for this patient. So my choice would be FOLFOX for this patient. Hello? Am I audible?
Yes, sir. Yes, sir. Please continue, sir.
Yeah, so FOLFOX would be my choice for this patient. Considering this patient is progressed on first line.
I think bilirubin is
Go to bilirubin.
no, this is not now. Or this is now?
No, this is now. Latest value.
They have written 2023.
30.
It's not 2023.
Means at the time of consultation. When we had this case, these are the old cases, so it will be like that.
Acha. Okay.
Yeah.
Okay. So if it
So
was
like at
30,
that
then
point of
basically care
time,
is better.
at that
If it
point
was
of
30
time,
at the point of
yeah.
consultation.
Yes, ma'am. Yes, sir.
If it was 30 at the time of consultation, I saw AST/LT, I missed bilirubin. If it was 30 at the time of consultation, then it is better to do just best supportive care for the patient rather than treating him further, her further.
And what about the immunotherapy, sir? Can you go down to the questions, please?
No, already durvalumab was given at
Yes,
first
sir.
line. Yeah, so I don't think we should give second line immunotherapy.
Yeah, and for the kind of disease the patient had done relatively well, and we don't know all these headaches and all could be the patient could have developed brain mets also for all you know. She's neuroendocrine carcinoma, so best to just give her supportive care.
And role of stenting, palliative radiation. I think palliative radiation therapy to lungs
I don't
have.
think palliative radiation therapy to the lung is also an option. Stenting can be if there is some intrahepatic biliary
Yeah.
dilatation, at least so the patient can be relieved of the symptoms of itching and cholangitis. That's about best we can do. I don't think that bilirubin will ever come back to baseline also.
Any questions from the participants? No questions? Okay. We'll go to the next case. Fourth case. Ms. Pauna, please.
So our fourth case is a 56-year-old female with family history of cancer. Sister had breast cancer and another sister had lung cancer. Patient is a known case of type 2 diabetes mellitus on glipizide. Patient presented with complaint of right abdominal pain and emesis, July 2023. Triphasic CT abdomen pelvis showed gallbladder lesion, multifocal, polypoidal, largest measuring 1.6 into 1.3 centimeter, gallbladder wall thickening, distension of 0.9 centimeter, common bile duct dilatation, few periportal portocaval lymph nodes, largest measuring 2 into 1.3 centimeter, few subcentimetric gastrohepatic lymph nodes, hepatomegaly, hepatomegaly 18 centimeters, no evidence of peritoneal ascitic fluid, no evidence of malignancy elsewhere. Radiology note gallbladder lesion with wall thickening, no obvious extension of lesion outside the gallbladder wall, few enhancing periportal and portocaval lymph nodes, concern of malignant transformation of polyps, no intra or extrahepatic biliary duct dilation. CA 19.9 was elevated to 35.7 on July 12, 2023. CA was elevated to 4.9 on July 12, 2023. MRI MRCP showed gallbladder lesion, multifocal, polypoidal, largest 1.6 into 1.3 centimeter, gallbladder wall thickening, distension of 1 centimeter 1 centimeter CBD dilation, small distal narrowing, few periportal portocaval lymph nodes, largest 2 into 1.3 centimeter lymph nodes, no evidence of malignancy elsewhere. Radiology note showed gallbladder lesions with wall thickening, no obvious extension of lesion outside the gallbladder wall, few periportal and portocaval lymph nodes, concern for malignant transformation of the polyps. Note metastatic workup prior to surgery not available. Patient underwent curative definitive upfront laparoscopic open radical cholecystectomy on July 19, 2023. Operative note distended gallbladder with thin omental adhesion. Pathological tumor site gallbladder, final margins of the surgery positive. Note cystic duct margin involved by carcinoma, cystic duct involvement positive, hepatic perimuscular connective tissue involvement positive, peritoneal perimuscular connective tissue positive, liver involvement not noted, serosal involvement negative. Number of retroperitoneal periportal lymph nodes resected were 1 and was positive for tumor deposit. Number of hepatic artery lymph nodes resected were 4 and 1 of which was positive for tumor deposit. Malignant disease adenocarcinoma, cancer grade 2. Pathology note invasive adenocarcinoma, biliary type with focal area of signet ring cell morphology and extracellular mucin. The tumor diffusely infiltrates the wall of the gallbladder and extends from the fundus to cystic duct. Pathological tumor size of 8. positive lymphovascular invasion, perineural invasion negative, pathological TNM stage of stage 3B, T2B, N1MX. Patient underwent a second surgery with curative definitive upfront, common bile duct resection with hepatojejunectomy on July 25th, 2023. Final surgical margins were negative. Malignant disease adenocarcinoma. Pathology note: intramural spread of gallbladder adenocarcinoma. US chest showed no evidence of malignancy, mild pleural effusion and basal atelectasis. July 26, 2023. Note from the clinical note and source report not available. On August 26, 2023, TMC NCG Navya has recommended adjuvant chemotherapy with capecitabine or S1 regimen or capecitabine and cisplatin. Their treating oncologist has went with gemcitabine and capecitabine option. Patient underwent curative definitive adjuvant chemotherapy with gemcitabine and capecitabine from August 28, 2023 to December 12, 2023. FTG PET-CT of January 15, 2024 showed few epiphrenic lymph nodes largest 0.5 into 0.4 centimeter along right side with low FTG avidity. Bilateral level 1B, 2, 3 cervical lymph node largest 1.2 into 1 centimeter with SUV 2.6. Mediastinal lymph node largest 1.8 into 1 centimeter at right lower paratracheal lymph nodes with low FTG avidity. No evidence of malignancy elsewhere. Radiology note: no evidence of disease recurrence in the operative bed. Cervical and mediastinal lymph nodes are suggestive of reactive. Note: the treating oncologist considered the lymph nodes as reactive and no treatment was given. There were no symptoms with her. FTG PET-CT of April 10, 2024 showed bilateral level 2 cervical mediastinal hilar lymph nodes, largest 1.3 into 1 centimeter, left level 2 cervical lymph nodes with an SUV of 7.9, 1.5 into 1 centimeter right upper paratracheal lymph nodes with SUV 5.4, 1.9 into 1 centimeter right supraclavicular lymph nodes with an SUV of 4.5. Retroperitoneal lymph node largest 1.7 into 1 centimeter, aortocaval lymph nodes SUV 3.2, few epiphrenic lymph nodes largest 0.5 into 0.4 centimeter along right side, low FTG avid, no evidence of malignancy elsewhere. Radiology note: there is increase in the size with interval appearance of metabolic activity of the prior noted retroperitoneal lymph nodes. Query metastatic, query inflammatory. There is mild increase in the size and metabolic activity of the prior noted bilateral level 2 cervical, right supraclavicular and mediastinal lymph nodes, likely infective, inflammatory. Diagnosis made by fine needle aspiration cytology of the supraclavicular lymph node showed metastatic adenocarcinoma, metastatic supraclavicular lymph nodes, and metastatic for retroperitoneal lymph nodes. Clinical TNM stage was stage 4, NET, NEN, M1. MSI stable, PDL1 positive with 5% on April 17, 2024. CPS score was 15, CA 19.9 elevated to 32. On April 30th, 2024, TMC NCG Navya online expert opinion. I'm sorry. On April 30th, 2024, TMC NCG Navya online expert opinion recommended chemotherapy with FOLFOX regimen, and if affordable and feasible, addition of immunotherapy with long intervals is recommended. Diagnosis made by somatic testing gallbladder. 533 gene panel showed ERBB2 positive, NF1 positive, ELF3 positive. Somatic testing note predicted sensitivity for famtrastuzumab deruxtecan, neratinib, tucatinib, and adotrastuzumab emtansine, pertuzumab, and predicted resistance for other anti-HER2 therapies, including trastuzumab, margetuximab, ditosylate for ERBB2 mutation, trametinib and selumetinib have potential benefits for NF1 mutation. MSI stable. Tumor mutation burden was 6.9 mutes per MB. Somatic testing was negative for ARC-PROC, CHEK1, EGFR, FGFR, HRR pathway, gene status, KRAS, MET, NRAS, NTR. Serum creatinine of April 6, 2024 was 0.58. LFT of April 6, 2024 showed AST of 134, ALT of 89, alkaline phosphatase 1.25, all of which elevated. Globulin GGT also elevated. Cardiac function tests were not available. Functional ECOG score of 0 to 1. General condition, able to do activities of daily living without assistance. No significant disease-related symptoms. Resource constraint. Patient has up to 10 to 15 lakhs per annum, so no resource constraint. Patient preference note. The caregiver is concerned and wants to know if targeted therapy is needed now or if chemotherapy along with immunotherapy is recommended. Given high cost of immunotherapy, benefits of adding immunotherapy to chemotherapy. Current plan for chemotherapy with FOLFOX along with immunotherapy with durvalumab. Caregiver seeking options on further treatment plan. Given disease progression and PD-L1 positive and progression on GemCap, role of FOLFOX durvalumab versus pembrolizumab or durvalumab with gemcitabine cisplatin versus alternate. As per patient preference, could the addition of immunotherapy benefit huge in the survival? Given HER2 positive, role of targeted therapy with trastuzumab deruxtecan versus trastuzumab pertuzumab versus tucatinib trastuzumab now versus preserve for subsequent line setting. Are additional diagnostic tests recommended?
Now I request Dr. Prabhat Bhargava to start the discussion. Sir, please.
Yeah. Can you once again summarize this patient? Post-op patient received GemCap, that within 3-4 months patient had progression and was advised FOLFOX, and then all these tests were done. And what mutations are positive?
Go on.
Yeah, HER2, NF1, and ELF3. Okay. And FOLFOX is ongoing or patient has not yet started FOLFOX?
I think it is ongoing. Let me just scroll. Gemcitabine, then put on.
Then FOLFOX was advised by the expert panel.
Yeah, but they are planned for FOLFOX. They have not yet started.
Okay.
Yeah.
So we know that GemCis is the best regimen for gallbladder cancer. So patient had received GemCap. So Gem and Cape, that is Gem and 5-FU patient had already received. I would re-challenge this, and nothing else is more potent. So I would re-challenge this patient with GemCis rather than FOLFOX would be my plan. To give platinum along with gemcitabine, re-challenge gemcitabine with an addition of platinum. And then we can add durvalumab as first-line therapy. GemCis and durvalumab would be my choice. Because patient has a mutation in HER2, NF1 mutation salutamab is not available in India and it is only approved for children's. For HER2 mutated cancers, only lung cancers HER2 mutation and HER2 is approved. But for other cancers, it is HER2 amplification which is required and not mutation. So HER2 mutated gallbladder cancers, there is no role of the NHER2 right now. So for only GemCis durvalumab would be my treatment of choice for this patient.
Right, sir. Ma'am, would you like to add anything for this patient, Dr. Patkar?
No, nothing. Whatever Prabhat says.
Okay, ma'am. So one general question to both the experts. So what are the recent advances that we are seeing in gallbladder cancer management? Because as we know, the treatment options are less, the presentation is delayed, there is still, the patients are struggling to get proper treatment and all those things. So like what are the recent investigations going on to uplift the condition here?
So in adjuvant setting, we have done a trial, a small trial where K party was compared to Gemsys, and both are almost head to head at 1 year, which was the primary endpoint, and secondary endpoint I would be presenting at 3 years at this ESCO. So I cannot disclose the outcome till now. The second improvement was gemcitabine addition of trastuzumab to gemcitabine in HER2 positive gallbladder cancers, biliary tract cancers, where we have done a trial in first line setting. Patients who were HER2 positive, we added trastuzumab to gemcitabine and cisplatin, and there was improvement in progression-free survival. So we are running a second trial now as a randomized phase 3 trial to see whether chemo versus chemo plus trastuzumab has any benefit over just giving chemotherapy in randomized fashion. But phase 2 single arm trial was positive. At the same time, there were 2 other trials in second line of trastuzumab going on, where Folfox plus trastuzumab was given in single arm phase 2 single arm setting, and it was positive. So if those who are not given in first line can be given in second line, Folfox plus trastuzumab or deruxtecan in second line. Only deruxtecan. That was also one of the trial which was going on simultaneously. So 3 trials have been done simultaneously. We did in first line. Trastuzumab and HER2 was done in second line, single arm, and Folfox plus trastuzumab and second line therapy in single arm was done. So 3 trials have come positive. But whether those who have received trastuzumab in first line, will they continue to benefit? This is positive in breast. We can continue trastuzumab, but not true for stomach cancers. So what will happen to gallbladder cancers, that time will say. I am doing a trial right now of single arm phase 2 of TDM1, which is freely, generic is available in Indian scenario. TDX will still not be feasible for most of the patients for next 5 to 7 years. So doing TDM1 as second line therapy is a trial going on. We are actively recruiting from 42 patients we want total. 24 we have already recruited. So this is what was major advances. And in metastatic setting, we can add durvalumab or pembrolizumab with first line therapy of gemcitabine cisplatin if patient is feasible. It is a luck game which patient responds. Roughly 10% additional patients will respond to immunotherapy, and Gemsys is standard of care as first line therapy. So this is how I will summarize.
Thank you, sir. Thank you so much. Ma'am, from you, ma'am, on the surgical aspects, please.
So apart from minimally invasive, no other advances in surgery as such. So as long as we can achieve an R0, whether it is done via open route or minimally invasive, it doesn't make a difference. We are doing robotic as well as laparoscopic surgeries for gallbladder cancer. And a little bit that some kind of neoadjuvant, if we are able to give and downstage these patients, then these can be offered resection. So we are running a randomized trial for neoadjuvant chemo versus chemo radiation. That also will give us some better idea. That's about surgical advances. I mean, apart from minimally invasive, nothing much has come in terms of advancement for surgery for gallbladder. There is no great role of doing any heroic extended resections or hepatopancreatoduodenectomy. So that's about it.
Any take-home message, ma'am, for all the participants? Just let us end with a take-home message.
So take-home message is that, I mean, it is prudent to identify gallbladder cancer in early stages. We still don't know what is the best way to do it. But if we can, then stage 1, stage 2 disease has excellent survival with a curative surgery. It is prudent to do the correct surgery, what is needed, with adequate lymph node dissection and a good liver margin, and then subject the patient to adjuvant based on the final stage. And in certain subset of locally advanced patients, there is a role of offering them some kind of neoadjuvant downsizing and then operating.
Thank you, ma'am. Dr. Bhargava, your message, take-home message for the participants.
Yeah, same for the participants. It would be prudent to keep in mind that 5-FU and gemcitabine are the backbones from chemo perspective. You should not use them. You should use them judiciously, one after the other, to give them maximum benefit for survival.
Thank you, sir. I think there are no more questions from the participants also. If anybody has any question, you can please post it here. Otherwise, we will end the session. I thank the panel members, Dr. Shraddha Patkar and Dr. Prabhat Bhargava and Dr. Rakesh Kapoor, had to go in between for a meeting. I thank you for sparing your valuable time and sharing your experience and expertise with all the participants and guiding the case management and giving insights into the recent advances and the development that are taking place in the field of gallbladder cancer. Thank you, ma'am, and thank you, sir. Thank you for extending your support to us despite of having a busy schedule. Thank you, ma'am. And Dr. Bhargava, thank you, sir. And I thank all the participants for sparing their time and attending the webinar. Please provide your feedback in the survey that you get once you exit. Thank you, ma'am. Thank you, sir. And thanks, everyone. Bye-bye.
Thank you. Bye-bye.
Thank you.